Imagine for a moment you hear that fire alarm. That immediate sense of danger, the heat, the flames. It's terrifying, right? That visible threat. But what if the real killer, the deadliest part, isn't what you see? What if it's, invisible?
Welcome to the deep dive. Today we are tackling a silent enemy, smoke inhalation injury. We see the burns, they're awful obviously, but so often it's the internal damage from the smoke itself that leads to the worst outcomes, usually respiratory failure. So our mission today is to really get under the hood. Why is smoke inhalation so devastating? How does it work? Its damage unseen. And what are experts doing to fight back? We've gone through a whole stack of detailed reviews, the latest research, basically to give you the inside track on this. Let's unpack this hidden threat.
It's absolutely critical for anyone in emergency response or medicine. Assessing and managing smoke inhalation injury, SI we often call it, has to be top priority. It doesn't matter how bad the visible burns are, or even if there aren't many. That internal disruption you mentioned, that's often the real life threat.
And it's not like all smoke is the same, is it? It's a real mix of nasty stuff. Exactly. It's this heterogeneous mixture. Heated particles, different gases, toxic chemicals all swirled together. And what's in that smoke, how bad it is, depends entirely on what's burning, the fire temperature, oxygen levels, how long someone was exposed.
So house fire versus a wildfire could be completely different dangers chemically.
Completely different. Different materials burning mean different toxic cocktails.
Okay, this is the part that really gets me, the insidious nature of it. You'd think someone breathing smoke would be obviously struggling right away, but the research highlights this paradox. Patients can seem okay, almost stable at first, gives you a false sense of security, but then, boom, symptoms, especially for the lower airways, might not show up for 24, even 48 hours. Like pulmonary edema fluid in the lungs maybe not hitting until 36 hours later.
Which leads to that rapid, unpredictable decline. It's why being proactive, observing patients closely for at least 6 to 24 hours, is so vital. You can't just trust that initial assessment.
So it's not a single event, it unfolds in stages.
Precisely. We typically see 3 clinical phases in severe cases. First, the early phase, say within the first 24 hours. Here, the symptoms are mostly driven by the immediate hit from gases like carbon monoxide, hydrogen cyanide, and also direct thermal injury, the heat damaging the upper airways.
Right. Then comes the intermediate phase.
Yeah, that's usually from about 12 hours up to maybe 5 days post-exposure. This is where we often see the pulmonary edema really develop, along with a major systemic inflammatory response, the whole body reacting.
And the final stage.
The late phase.
Yeah.
Kicking in after 5 to 7 days, sometimes longer. This is often when complications like bronchial pneumonia set in. Basically, the lungs cleaning mechanisms, the cilia, the macrophages, are damaged by the smoke, making them super vulnerable to bacterial infections, especially gram-negative ones.
Nasty stuff. And you also mentioned a potential brain issue.
Yes. Another late outcome can be delayed post-hypoxic leukoencephalopathy. It's a type of brain damage triggered by the initial lack of oxygen.
Okay, so we have the timeline. Let's break down how the smoke actually harms the body. What's its arsenal? First up, thermal injury. We think fire, we think heat. But inhaled, hot air cools fast, right? So the direct heat damage is mostly upper airway. Pharynx? Larynx?
Mostly, yes. Hot, dry air cools pretty quickly as it travels down. The big exception, though, is steam. Steam holds vastly more heat energy. It can absolutely cause significant thermal burns deeper down in the lower airways.
And what does that heat damage do?
It causes the lining of the trachea and bronchi to slough off, triggers intense inflammation, rapid swelling, edema, blisters can form. And all this can lead to acute airway obstruction. Basically, the airway swells shut.
Scary. Okay, beyond the heat, there's the chemical injury, the gas attack, as you called it.
Right. You've got irritant gases, things like hydrogen chloride, sulfur dioxide, ammonia, aldehydes. They dissolve in the moisture lining our respiratory tract and cause immediate irritation and inflammation. And there's a key difference here based on solubility. Highly water-soluble gases, like ammonia or chlorine, cause that instant severe upper airway irritation, burning eyes, coughing fits, laryngospasm.
Which might actually save someone by making them flee.
Exactly. They act as warning signs. But then you have the less soluble gases like nitrogen dioxide or phosgene. These guys bypass the upper airways more easily and penetrate deeper. Fewer immediate warning signs, but they cause delayed and often much more severe damage down below pulmonary edema, ARDS. Much more insidious.
And what about the actual particles in the smoke?
Particulate matter, crucial component. We're talking microscopic stuff, PM10, PM2.5, smaller than a speck of dust. You inhale these, you get irritation, burning eyes, runny nose, cough, wheeze. But the real problem is they get deep into the lungs. They cause inflammation down there and can seriously worsen conditions like asthma or COPD if someone already has them.
So we've got heat, chemical burns, particles. But then there's the stuff that gets into the bloodstream and poisons the whole system, right? The asphyxiants.
Yes, this is where systemic toxicity comes in, primarily from carbon monoxide, CO, and hydrogen cyanide, HCN. These are the invisible killers.
Let's start with CO. Odorless, colorless, comes from incomplete burning.
That's right. Its main danger is its incredible attraction to hemoglobin in our red blood cells. It binds about 210 to 250 times more strongly than oxygen does. So it forms carboxyhemoglobin, COHB, and basically kicks oxygen off the bus, reduces the blood's oxygen carrying capacity dramatically.
But it's not just about carrying oxygen, is it?
No, and this is key. CO also directly poisons the mitochondria, the energy factories inside our cells. It inhibits an enzyme called cytochrome C oxidase, which is essential for using oxygen to make ATP, cellular energy. So you get profound tissue hypoxia even if oxygen's getting delivered. The cells just can't use it properly.
Wow, and the symptoms depend on how much CO is in the blood.
They do. Mild levels, maybe 15-20% COHP, you get headache, nausea. Get up to 20-40%, you see disorientation, fatigue. Severe poisoning, coma, seizures, heart problems, even permanent brain damage.
Okay, then there's hydrogen cyanide, HCN. Where does that come from?
Burning synthetics, plastics, nitrogen-containing stuff like wool, silk, polyurethane foam, common in house fires. And its mechanism is terrifyingly similar to CO2 in one way. It also inhibits that same mitochondrial enzyme, cytochrome C oxidase, blocks aerobic metabolism, shuts down ATP production, histotoxic hypoxia again.
Cells are drowning in oxygen they can't use?
Precisely. It hits the brain and heart hardest, very fast.
Early on.
Headache, anxiety, confusion that rapidly progresses to trouble breathing, arrhythmias, unconsciousness, cardiovascular collapse. And because cells switch to anaerobic metabolism, you get a massive buildup of lactic acid, severe metabolic acidosis.
And I read something truly chilling that CO and HCN together are worse than just adding their effects.
Much worse. It's a synergistic effect. Concentrations of each gas that might not be lethal on their own can become deadly when inhaled together. They attack from both ends, reducing oxygen delivery and preventing oxygen use. It's a devastating 1-2 punch to cellular respiration.
So put it all together, heat, chemicals, CO, HCN, what's the overall physiological fallout?
It's a cascade. Severe tissue hypoxia forces that inefficient anaerobic metabolism, leading to metabolic acidosis and high lactate levels. You get a massive inflammatory response in the lungs, cytokines firing off, capillaries getting leaky, neutrophils rushing in, causing significant pulmonary edema, fluid buildup in the lung tissue itself.
And the airways get blocked.
Yes, from multiple angles. Swelling, edema, muscle constriction, bronchoconstriction, tons of mucus production, bronchorrhea, and the damaged lining slouging off, sometimes forming these thick plugs called fibrin casts.
Leading to...
Potentially, yes. All this causes diffuse damage to the alveoli, the tiny air sacs. Fluid leaks in, causing more pulmonary edema. If it's bad enough, it progresses to acute respiratory distress syndrome, ARDS, life-threatening. And again, it can happen fast or be delayed up to 48 hours. It's a vicious cycle.
Okay, so given how sneaky and complex this is, how do doctors actually figure out if someone has SII, especially when time is critical?
Diagnosis is definitely a challenge. You often don't have immediate definitive lab results or clear imaging right away, and relying on initially normal tests can be really dangerous because of that potential for rapid decline and delayed symptoms. So the most important tool initially is high clinical suspicion.
Meaning
you look at the whole picture, the history, were they trapped in an enclosed space, what kind of materials were burning, if known, and then the physical exam. Are there signs suggesting exposure? That suspicion guides everything.
What kind of signs and symptoms are we talking about, both immediate and delayed?
Immediately, you might see coughing, wheezing, maybe stridor, that high-pitched noise indicating upper airway narrowing, hoarseness, shortness of breath, maybe headache, dizziness, confusion if CO or cyanide are involved. Physical signs like facial burns, singed nose hairs, soot around the mouth or nose or in the spit. That black or gray saliva is a big clue. Elevated heart rate, fast breathing too.
And the delayed ones to watch for.
Worsening shortness of breath, feeling like it's harder and harder to breathe, a persistent cough that wasn't there before, and increasing signs of that upper airway swelling. Those need immediate attention.
So beyond suspicion and physical exam, what tools do doctors use? Imaging, labs?
History and physical are paramount first steps. For imaging, chest x-rays. Honestly, they're often normal early on, even with significant injury. They're just not very sensitive initially. CT scans are generally much better. They can show lung abnormalities like interstitial markings, ground glass appearance, thickened bronchial walls, even when the X-ray looks clear. More useful if the patient has symptoms despite a normal X-ray.
And lab tests.
Arterial blood gas, ABG, is crucial. You're looking for metabolic acidosis, elevated lactate, big red flags, especially with hypoxia or suspected COHCM poisoning. COHB levels are essential for CO poisoning. Levels over, say, 25–30% means severe poisoning. But, and this is important, the level can be falsely low if the patient got oxygen before the blood draw, because oxygen helps clear CO. And COHB levels don't always correlate perfectly with how bad the neurological outcome might be.
You mentioned lactate earlier as a clue for cyanide.
Yes, it's a really useful surrogate marker because direct cyanide testing takes too long. If a smoke inhalation victim has a very high lactate level, like over 10 millimarker, you have to strongly suspect cyanide poisoning. It prompts faster treatment.
Any other blood tests?
People are looking at inflammatory biomarkers, things like SAA, IL-6, IL-8, TNF-alpha. They might correlate with how severe the injury is. But right now, there's no single perfect biomarker test. Still an area of research.
So what's the definitive way to know what's going on inside the airways?
The gold standard, really, is endoscopic evaluation using a flexible fiber optic bronchoscope. This lets clinicians actually look inside the airways. They can directly see the extent of the damage. Redness, charring, soot deposits, swelling, ulcers, the mucosal lining peeling away. It's the most reliable diagnostic tool.
And you said it can be used for treatment, too.
Absolutely. That's a huge advantage. During bronchoscopy, you can perform an airway washout lavage to clear out soot, debris, and those thick secretions or fibrin casts. This therapeutic aspect significantly improves outcomes by helping to keep the airways clear.
Okay, let's pivot to treatment. Saving lives. What's the playbook? Airway first, I assume.
Airway, airway, airway. It's the absolute top priority. Early, often preemptive, intubation, putting in a breathing tube is critical if there's significant exposure. Signs like facial burns, stridor, respiratory distress, that carbonaceous sputum, altered mental status, or even just extensive skin burns, any of those might warrant early intubation.
Why preemptive? Why not wait and see?
Because that airway swelling, the edema, can happen incredibly fast. If you wait too long, the airway might swell completely shut, making intubation extremely difficult or impossible. It's much safer to secure the airway early. And often, a slightly larger endotracheal tube is preferred, thinking ahead for potential bronchoscopy or needing to suction out thick secretions later.
And oxygen, obviously.
Cornerstone, immediate 100% oxygen, usually through a non-rebreather mask. This is vital for both the lung injury itself and especially for CO poisoning. High-flow oxygen helps displace CO from hemoglobin much faster.
What about hyperbaric oxygen, HBO?
That's more specialized. Reserved for severe CO poisoning. We're talking very high COHB levels, over 25–30%, or evidence of end organ damage like cardiac issues, neurological problems, severe acidosis, unconsciousness. Also strongly considered for pregnant patients with CO poisoning. HBO forces much more oxygen into the blood and tissues, clears CO even faster, and seems to reduce the risk of those long-term neurological problems. But, not every hospital has an HBO chamber.
Fluids are needed, but you mentioned being careful.
Very careful. Fluid resuscitation is necessary, especially with associated burns, but you have to walk a fine line. Too much fluid can worsen pulmonary edema in lungs that are already leaky and inflamed from the smoke. The goal is adequate hydration, maintain urine output without fluid overloading the lungs, often using something like Ringer's lactate. And interestingly, SII patients might need more fluid than predicted just by burn size due to fluid loss from the injured lungs.
Okay, what about medications? Any drugs that help?
We use bronchodilators like albuterol or protropium if there's bronchospasm, wheezing, or tightening of the airways. Eucalyptics like N-acetylcysteine, NAC, can help break down thick mucus, sometimes given nebulized, though it can irritate the airways itself, so often given after a bronchodilator.
I saw nebulized heparin mentioned. That sounds unusual.
It is, but showing promise. The idea is that heparin, normally an anticoagulant, might reduce inflammation and prevent those fibrin casts from forming in the small airways when inhaled, might improve microcirculation too. It's still being studied actively.
What about things like antibiotics or steroids? Should they be given routinely?
Generally, no. This is important. Prophylactic antibiotics, giving them just in case, isn't recommended. Doesn't seem to prevent pneumonia and can lead to resistance. Antibiotics are only used if there's a confirmed infection. Same for systemic corticosteroids. Routine use isn't beneficial and might even be harmful, potentially impairing healing or increasing infection risk. Very specific situations only, like maybe severe post-extubation stridor.
Makes sense. Pain control is important too, I imagine.
Essential, both for patient comfort and to allow things like breathing exercises or physiotherapy, using a combination of NSAIDs, maybe alpha-2 agonists, and opioids as needed.
And specific antidotes for the poisons. Cyanide.
Yes, and for cyanide, treatment needs to be started based on clinical suspicion immediately. You don't wait for lab confirmation. It takes too long. The primary antidote nowadays is hydroxycobalamin. It binds directly to cyanide, forming cyanocobalamin, essentially vitamin B12, which is harmless and easily excreted. It works fast, has few side effects, and crucially, it's safe to give even if the patient also has CO poisoning. That's a major advantage.
Are there others?
Sodium thiosulfate is another option. It helps the body convert cyanide to the less toxic thiocyanate, also safe with CO poisoning. Older antidotes like nitrites induce methemoglobinemia, which binds cyanide, but they are generally avoided if CO poisoning is also suspected, because making methemoglobin further reduces the blood's oxygen-carrying capacity, which is already compromised by CO, so generally not the first choice anymore.
And if someone does develop methemoglobinemia?
The antidote for that is methylene blue.
So once the patient is stabilized through that acute phase, what comes next? Recovery isn't instant.
Far from it. Aggressive pulmonary hygiene is absolutely crucial during recovery. This means things like therapeutic coughing, deep breathing exercises, getting the patient moving early, ambulation, chest physiotherapy, regular suctioning. Anything to help clear secretions and prevent the lungs from collapsing or getting infected.
It sounds like actively preventing complications.
It is. This isn't just supportive care. It's active treatment to prevent progression to pneumonia, ARDS, or atelectasis. And ongoing monitoring is key. Patients remain at high risk for pneumonia, ARDS developing later, lung scarring, pulmonary fibrosis, collapsed lung, pneumothorax, ventilator-associated pneumonia if they're intubated. You have to stay vigilant.
How long does recovery typically take? Any long-term issues?
It can take weeks, even months. And yes, long-term effects are common. Persistent shortness of breath, a chronic hoarse voice, recurrent wheezing. Many patients need inhalers long-term and require regular follow-up with lung specialists. Pulmonary rehabilitation programs can be very beneficial in helping regain function and improve quality of life.
You know, connecting this to the bigger picture, it really highlights that not everyone is affected the same way. You need tailored care for different groups, right?
Absolutely. Vulnerable populations need special consideration. Pediatric patients, for example. Their physiology is different. They breathe faster relative to their size, so they inhale a larger dose of toxins per pound of body weight. They also have smaller airways, more prone to obstruction. And behaviorally, kids might hide during a fire, leading to longer exposure times. Managing them needs a specialized, multidisciplinary team, careful airway management, and specific lung protective ventilator strategies if needed.
And pregnant women.
A major concern, especially with increasing wildfire smoke exposure. Studies have linked smoke exposure during pregnancy to risks for both the mother, like gestational diabetes, more ER visits, and the baby. For the fetus and infant, risks include preterm birth, low birth weight, potentially impaired lung development leading to later respiratory problems, even things like cleft lip.
So, specific advice for them during smoke events?
Yes. Stay indoors as much as possible, use HEPA air filters, monitor air quality indexes closely, avoid strenuous activity outdoors.
What about people who already have health problems?
Patients with pre-existing conditions, asthma, COPD, heart disease, diabetes, kidney disease, they're at much higher risk. Smoke exposure can severely exacerbate their underlying illness. Their management needs meticulous attention to both smoke injury and their chronic condition.
It's clear this is a complex field. Are things changing? What's new on the horizon for managing SAI?
Oh, definitely. The field is constantly evolving, moving towards more precise, more personalized approaches.
Like what kind of new therapies?
Well, there's exciting research into novel therapeutics. For instance, stem cell therapy, mesenchymal stem cells, MSCs, are being studied for acute lung injury. They seem to have potential for tissue repair and calming down that intense inflammation. Early days, but promising.
And you mentioned inhaled heparin earlier.
Right? Inhaled anticoagulants like nebulized heparin are being explored more formally to target inflammation and prevent those fibrin casts that block airways. Other things in the pipeline include looking at hydrogen sulfide, peroxynitrite decomposition catalysts, and treatments currently in clinical trials like high-frequency percussive ventilation or using substances like perfluorohexene to help lung function. Lots of investigation happening.
What about diagnostics, getting better at figuring out who's injured and how badly?
That's a huge focus. Research into new biomarkers aims to find specific molecules in the blood or breath that can accurately tell us the severity of the injury, predict the patient's likely outcome, or even help distinguish SII from other conditions. We talked about IL-6, IL-8. Earlier researchers are looking for even better ones.
And technology, AI maybe.
Artificial intelligence, AI, has massive potential here. Imagine AI analyzing CT scans to pick up subtle signs of injury humans might miss, or integrating data from monitors, labs, and patient history to predict who's likely to deteriorate. AI could help optimize ventilator settings in real time for individual patients, streamline how we interpret complex data, maybe even enable better remote monitoring. It could really revolutionize respiratory care.
Wow. Any other tech angles?
Nanotechnology is another exciting frontier, developing nanoparticle-based systems to deliver drugs directly to the injured lung tissue. This could mean getting higher concentrations of medicine exactly where needed, increasing effectiveness while minimizing side effects elsewhere in the body. Targeted delivery.
So what does all this add up to? Stem cells, AI, nanodelivery?
It adds up to a powerful trend towards precision medicine, moving away from one-size-fits-all approaches towards treatments tailored to the individual patient's specific injury profile and needs. The convergence of these new therapies, better diagnostics, AI analytics, targeted delivery, it really could transform the outlook for patients with smoke inhalation injury, a condition that's historically been very difficult to treat with high rates of illness and death.
It sounds like a future where maybe AI analyzes your unique biomarkers and recommends a specific stem cell therapy delivered via nanoparticles just for you.
That's the direction things are heading. Personalized, targeted, more effective care.
So wrapping this up, smoke inhalation injury is clearly this incredibly complex beast. You've got the heat, the chemicals, the systemic poisons like CO and cyanide, often working together in devastating ways. And its hidden nature, the delayed onset, the potential for rapid decline. It just hammers home why doctors need that high index of suspicion, why that proactive multidisciplinary care is so absolutely critical.
Absolutely. And the landscape is shifting. Research, technology. They're constantly giving us new tools, better understanding, and hopefully improving outcomes, reducing long-term problems for people who survive these events.
Which leads to a final thought for you, our listener. Given how invisible and insidious smoke inhalation injury is, and thinking about these incredible advances in diagnosis and treatment, how should our public health thinking evolve? How do we better protect vulnerable people, not just during a fire, but maybe living day to day in a world where wildfires and smoke exposure are becoming more common? Something to ponder until our next deep dive.